We have Dr. Namrata Sharma here. She's the chairperson of AIOSSC.
She's the best. She's the best.
She is
How
very
are you?
popular.
So we are live.
We have Dr. Satyan, who is the president of Glaucoma Society of India over here.
Amit sir, we are live.
Yeah, Doctor. Welcome, Dr. A.K. Ahmed.
Thank you.
So we are live.
So, good evening, everybody. So, welcome to the webinar of All India Ophthalmological Society, the global webinar of Gun In Glaucoma. So, an evening with Dr. A.K. Ahmed. Today is 8th October and the Indian time is 7:30. We'll have this webinar for 1 hour and Dr. A.K. is going to talk on the role of MIGS in modern glaucoma management. So, we have a chairperson, that is Chairman Scientific Committee of All India Ophthalmological Society. And we also have quite a few renowned panelists from India who all do MIGS surgery. So let me introduce each the panelist and the speaker. Before that, let me introduce myself, who's going to be a moderator. And basically, I am Dr. Amit Porwal. I'm head of the glaucoma services at Choitram Netralaya, Indore. I'm member scientific committee of AIOSSC and also ex-member ARC, that is Academic and Research Committee of AIOSSC, and executive member of Glaucoma Society of India. A teacher and trainer in glaucoma since 21 years and awarded with honorary FICO in glaucoma, AIOSSC Young Achievers Award, NIA Gold Medal, IRSA Gold Medal, and many such awards. I'm on the editorial board of Journal of Ophthalmic Research and Practice and have delivered more than 780 talks as invited guest faculty and have performed live surgeries and delivered papers, posters, and videos in various national and international conferences. I have 32 publications in peer-reviewed journals and authored 9 chapters in books. Next, we have our chairperson, none other than Dr. Namrata Sharma. She needs no introduction, but since this is a global webinar which is being broadcasted worldwide, I have to introduce her. She is specialist in cornea, cataract, and refractive surgery at AIIMS, New Delhi. She's done a fellowship from Moorfields Eye Hospital, London. She's the chairperson, Scientific Committee of All India Ophthalmological Society, president of the Cornea Society of India. She's got 2 patents on her name, that is Natasol and Natamatrix. She's the first Indian to be inducted as Director at Large International Member in the Cornea Society International of USA. Elected as a member of Afro-Asian Council of Ophthalmology, inducted as Council Member of Asia Cornea Society from India in the year 2024. She is a section editor for Cornea and External Eye Disease in the British Journal of Ophthalmology, that is BJO. And she was featured in 2023 Stanford list of top 10 highly cited ophthalmology researchers in India and in top 2% scientists in the world conducted by the Stanford University. Among the list of 100 top powerful women ophthalmologists in the world, and she is also among the top 100 most influential ophthalmologists in 2022 declared by the Asia Pacific Journal of Ophthalmology. She's got the Senior Achievement Award by the American Academy of Ophthalmology, International Ophthalmology Education Award, AAO, Best Video Awards by ESCRS, Ranzo, Best of Show Award 6 times by AAO. She's got over 600 publications in peer-reviewed journals and has authored 9 books. And she's the principal investigator in many multi-center international FDA trials and RCTs, which have changed the clinical practice all around. Coming to extreme panelists, I'm proud to introduce my mentor, Professor Dr. P. Satyan. He's the director of Satyan Eye Care and Hospital at Coimbatore Glaucoma Foundation. He's the president of Glaucoma Society of India, visiting consultant and professor for IBN Rashid Hospitals, Bahrain, former chief glaucoma services, Arvind Eye Hospital, Coimbatore, Tamil Nadu. He has undergone glaucoma training at Arvind Eye Hospital, Madurai, Bascom Palmer Eye Institute, Miami, Florida, John Hopkins Wilmer Eye Institute, Baltimore, and New York Eye and Ear Infirmary. Welcome, Dr. Satyan, sir. We have Dr. Manisha, who is the secretary for the Glaucoma Society of India. He's the director for Foresight Eye Center and Glaucoma Clinic, visiting consultant to Lilavati Hospital. He's also visiting glaucoma fellowship with Dr. Robert Rich and Dr. Joel Schumann, conducted numerous instruction courses in glaucoma at AIOS and GSI. He's with past treasurer of Glaucoma Society of India. Next, we have Dr. Dipanjan Pal, who is the senior consultant glaucoma and cataract services at Disha Eye Hospital, Kolkata, former chief medical officer at Preop Birla Arvind Eye Hospital in Kolkata, former member executive committee of Glaucoma Society of India. He's did his fellowship from Arvind Eye Hospital, Madurai. He's got publications in Index Journal and he's presented his work on glaucoma in national and international forums. Then we have Dr. Parul Ichupujani. She's a professor at Government Medical College and Hospital in Chandigarh. She's received a glaucoma training from BGI Chandigarh. She's done a clinical research fellowship under Dr. George Speight at Wills Eye Institute, Philadelphia. She's enlisted in the power list of best 40 under 40 ophthalmologists in 2014-15. She's member of the Education Committee, World Glaucoma Association, member of the Glaucoma Editorial Board, Indian Journal of Ophthalmology, and she has over 110 PubMed index articles with an RG score of more than 1,000. Next is Dr. Devendra Maheshwari, who's done his fellowship from Arvind Hospital, Tirunelveli, short-term glaucoma fellowship from Bascom Palmer Eye Institute, Miami. He's done observation at various institutes like the Kellogg Eye Center, University of Michigan, Wilmer Institute, John Hopkins, the New York Eye Infirmary, and many more places. He's got more than 50 publications in index and international journals. He's presently associated with a number of national and international studies and research work which are ongoing. Then we have Dr. Devang Angmo, who is an additional professor in ophthalmology at AIIMS. She's executive member of Glaucoma Society of India. She's got 140 research papers, over 35 book chapters, and 14 textbook contributions. She's got various national and international awards. To name a few, she's got the AIIMS Excellence Award, Best Free Paper Award in DOS, GSI Best Video Award. Coming to the international awards, she's got the Asia Award Travel Grant, World WGC Travel Grant, and she won the Young Investigators Award, and she's also part of the APO LDB alumni. And our last panelist, Dr. Siddharth Dixit, he is a consultant at VST Center for Glaucoma Care, LV Prasad Eye Institute, Hyderabad. He's done his fellowship PG from Christian Medical College, Vellore, DNB and Glaucoma Fellowship from LV Prasad Eye Institute, Hyderabad. He is the residency coordinator at LV Prasad Eye Institute. He's got special interest in angle closure glaucoma, lasers in glaucoma, MIGS, surgical innovations. So these were all the panelists and the chairperson, and it's my proud privilege now to introduce the star of this webinar, the speaker, Dr. Aik Ahmed. He is basically specialized in glaucoma, cataract, and anterior segment surgery. He is working at John Har and Hazel M. Robertson Presidential Endowed Chair and Professor, Department of Ophthalmology and Visual Science, University of Utah. Director Alan S. Kendall, Center for Glaucoma Innovation, John A. Moran Eye Center. Director Glaucoma and Advanced Anterior Segment Fellowship, which is proudly known as the GAS Fellowship in University of Toronto. Trillium Health Partners, and Chief Innovation Officers in Prism Eye Institute. I'm reading his CV a bit in detail because he's very popular in the mixed surgery and everybody should know what all work, tremendous work he's been doing. So Dr. IK is a fellowship trained glaucoma, cataract and anterior segment surgeon with a research and practice focus on the management of glaucoma, complex cataract and intraocular lens complications. He practices and is board certified in ophthalmology in Canada and the USA and is an active member of numerous national and international societies. He's done pioneering work in innovating glaucoma therapeutics, developing and coining the term, which is proudly called as a micro-invasive glaucoma surgery, which is known as MIGS. Dr. Ahmed has become one of the most recognized eye surgeons in the world and was recently recognized as #1 most influential ophthalmologist in the world by the news magazine The Ophthalmologist. Dr. Ahmed was selected as one of the Canada's top 40 under 40, a prestigious national award recognizing significant achievements at a young age. He is recipient of the prestigious Winkosh Medal at ACRS. The American Glaucoma Society honored him with AGS Surgery Day Lecture, and the UKI ACRS bestowed him with the Pierce Medal Lecture in 2015. In 2017, he was awarded the Innovator of the Year Award by the Eye Physicians and Surgeons of Ontario. Dr. Ahmed has a keen interest in development of advanced microsurgical devices and techniques in glaucoma and complicated cataract extraction, and is actively involved in research and medical education at a national and international level. He has designed innovative diamond scalpels for surgery, microsurgical instrumentation and devices, implants and techniques for the management of dislocated cataract, iris reconstruction, and glaucoma implant devices. He sits in the editorial boards of numerous journals, to name a few: Ophthalmology, Glaucoma, that is the Ophthalmology Glaucoma, Journal of Glaucoma, Canadian Journal of Ophthalmology, EyeNet, Ocular Surgery News, Cataract and Refractive Surgery Today, and is also a reviewer for numerous journals. In 2018, he was appointed as the Chief Medical Editor of Glaucoma Today. He has published over 200 peer-reviewed papers and has published books on glaucoma surgery, intraocular lens surgery, and advanced anterior segment surgery. He has won 5 Film Festival Awards, 10 Best Paper Sessions, and a Poster Award at ACRS, as well as an ESRS First Place Video Award and AO Best of the Show Award. So welcome, Dr. Aik.
Thank you very much, Ahmed. I'm so sorry for having to read through all that. But I was very impressed.
I wanted everybody to listen to this. Thank you. It's all yours now.
You're very kind, and I mean the hospitality that my Indian colleagues have always shown to the world is very evident, as you can see, and the achievements of all of you. So I'm humbled to be here, and I want to thank you and the panelists and you as chair here to have me here and moderating as well. And thank you all for listening. It's very much an honor. As most of you know, these are my roots. My roots are Indian, right? My parents are from India. And so I proudly speak here, even though I was born outside India, as a fellow Indian amongst you all here as well. And we truly have a global reach, of course, in ophthalmology and glaucoma. So I will get started and share my screen. I hope that we can generate some discussion as well, and I hope this will give you all some stimulation into where glaucoma is currently and where it's going. And so I've labeled my talk MIGS in the modern glaucoma world. These are my disclosures. And I'm going to speak on this topic from a perspective of philosophy, perspective of, re-looking at the pathology of glaucoma, and then speak about, the new paradigm in how we think about glaucoma. And I'll preface this by saying that what I say is certainly an evolution, and we need to still prove many of the hypotheses with which that many of us have come up with in terms of why and who and where to, treat glaucoma. But I still think we all can agree, and I'll say some things that are controversial, I hope, and people will disagree with. That's okay. Conversation and disagreement is what makes us progress and develop the right truth and the answer. But I think we agree that quality of life is what our goal is in glaucoma, but not just prevention of blindness, which we talk about, but also trying to improve the lives of our patients every day when they live with glaucoma. That means also reducing the adverse events on quality from our treatment. Like, for example, eye drops and issues around drops, of course. And also doing it in a way that we live in this world where we must think about access to all of our fellow human beings and develop the right cost-effective strategies, because, of course, these can add cost to the system. The current model, many places around the world, including here in North America, is we very much have a watchful and waiting way to think of glaucoma. We wait and we watch, and we intervene with aggressive surgery much later on when we have really no other choice to go. And this has, of course, been around for many, many decades for a good reason. We don't necessarily have the ideal options like we do, for example, with corneal surgery, with cataract surgery, refractive surgery, even VR surgery, where we feel comfortable intervening surgically earlier because of the risk, benefit, and effectiveness aspects. But this has led to a number of issues with our current paradigm, which we are well aware of. Compliance adherence is well known in any chronic disease like glaucoma, and this has been shown, understandably, to lead to more progression. Ineffective stacking medication, what I mean by that is adding second, third, fourth, fifth class of medication. We know from good data that adding more than 2 drops, for example, doesn't really give much of a meaningful drop in most patients, yet we see many patients that are on 2 or 3 or 4 medications, which of course reduces compliance and adds more adverse events, and doesn't really effectively lower pressure. 24/7 IOP control is always a challenge, whether it's from compliance or peaks and troughs. And then there's the histopathology example, which I'll talk a bit about. And so we do recognize there are challenges with our current paradigm. Now, it's interesting when we think about glaucoma, and I'm going to take a step back and go to pathology. I hope no one minds putting up some histology slides here. But think of glaucoma as a continuum of outflow dysfunction, where we go from a reversible disease to an irreversible disease, where we go from a disease that we can reverse to a situation where we have inflammation and fibrosis and sclerosis, where our treatments may not be as effective. And this leads into chronic downstream dysfunction beyond the trabecular meshwork and secondary disease that occurs with advancing disease. And so the idea of MIGS, interventional glaucoma, is to intervene earlier for the reasons that I talked about in my previous slides, and having a greater impact on a patient's life in a positive way, and taking the opportunity to do this earlier rather than waiting. I often say this: glaucoma is only young once, and that's the time when we can potentially alter the course of the disease, not just clinically, but possibly at a histopathological level, at the cellular level, and changing the approach from a reactive approach where we wait and watch to proactively dealing with glaucoma. And this has really been, I think, the era we're entering in of interventional glaucoma, a term that I've used to describe, an attitude of dealing with glaucoma in a way that we intervene earlier and more proactively. And I think this approach, we use advanced diagnostics, monitoring, intervening earlier, and hopefully safely, more aggressively, and addressing adherence. But of course, to do this, we have to be comfortable with the safety of the procedures. Just like cataract surgery, back many years ago, we were only doing cataracts and very dense cataract surgery, cataracts, because there is benefit in the unknowns. Now we do refractive lens exchange, even where we do clear lenses, even because of how comfortable we are with the risks. And that's where we need to be with glaucoma. And in glaucoma, I think we've seen this move forward. We're not there yet, of course, but SLT laser, for example, using it earlier in disease, more effective and has improved outcomes versus medications. We're seeing drug delivery. And of course, today we'll talk a bit more about MIGS and other options along that way. And so I will just say that glaucoma treatment is changing, where certainly the new paradigm, I think, is moving toward interventional therapies like SLT laser first line, drug delivery, even femtosecond laser, as you see in the video, MIGS, whether it's on its own or combined cataract, and then microinvasive bleb surgery. And so the future very much may move toward this interventional mindset from where we go medications to moving more toward interventional therapies where we use medications as a bridge. And we must think about our patient not just at one time point. Unlike refractive or cataract surgery, even corneal surgery, I know Namrata is here. I love cornea, of course, but glaucoma is a long-term chronic disease. We're always thinking about our patients and where do we intervene. And so there's many opportunities here. We think about where do we intervene. And certainly with MIGS, the ideal place to think about MIGS, as we've seen, is the patient with cataract. Because when we think of patient with cataract, we know many patients have coexisting cataract and glaucoma. And, you know, we've seen MIGS really proliferate, particularly with cataract surgery. So I'll focus a bit on this. In the question here is, when a patient presents to us with cataract and glaucoma, should we combine this? What should we combine it with? Should we do bleb surgery? Should we do MIGS surgery? Which one? Well, first of all, we do know that phaco does lower pressure. Now, it's modest, and medication reduction is modest, but we know that there's an effect. The idea of combining MIGS with cataract surgery is to try to achieve something more. And I'll show you that there is good data to support that. Most of all, it's important to remember that when we're already in the eye, this is a one-time opportunity to address glaucoma during the surgery. I give an example like astigmatism. We may think about a toric lens. This is a one-time opportunity to correct the astigmatism or presbyopia, for example, by doing it with cataract surgery. So just like we've seen refractive cataract surgery grow, we're seeing glaucoma and cataract surgery grow as well. And I hope that now in the future, we think about not only glaucoma in the context of cataract, but we think about a glaucoma patient who has a cataract, and therefore we think about addressing the glaucoma as well. Because right now, many people think about this in a perspective of, okay, a patient has a cataract and they happen to have glaucoma, so I'm going to do cataract. But maybe the perspective needs to change a bit. And our goals will be different for each patient, whether it's pressure reduction or medication reduction. And IOP reduction, of course, are when we need to lower the pressure, and medication reduction is secondary. In other patients, the goal may be to lower medication use, and IOP control is secondary to gain because we basically can lower medications achieving the same pressure. So this is different than traditional glaucoma surgery. And the error we make sometimes is trying to relate trabeculectomy to MIGS. These are different goals, different patient population as well. There are many different procedures to think about. Obviously, when we combine glaucoma surgery with cataract, we ideally don't want to disrupt our already excellent outcomes with our cataract patients, as we know from the recovery, the refractive benefit and stability, and everything associated with that. You know, the mechanisms, of course, are important. We know that phaco can be effective, particularly for angle closure. There is emerging data on the role of MIGS with angle closure, but most data we have is related to open angle glaucoma. And when we think about MIGS in the era of interventional glaucoma, we can think about this in the perspective of filling the gaps we have between our medications and lasers and our more traditional surgeries. Now, that's how we classify things today. MIGS, meaning physiological outflow procedures like Semmes canal-based procedures and supraciliar procedures, and then MIBS, which are subconjunctival microstents, which, have also evolved in their generation of creating safer and longer lasting blebs. I think we always think about our patients with glaucoma and ask them, do we need to consider combining this patient or do a bleb surgery? Because to me, it's very important still to remember, those of us that are glaucoma specialists here, that bleb surgery is still our most effective glaucoma procedure. Our patients who most need surgery, who are suffering serious vision loss, need bleb surgery. And these patients typically need more lower targets. And we do have now novel ways, traditional trabeculectomy and tube shunts, but now we also have microstenting and microshunting options that exist that provide potentially for safer options. And these procedures have really evolved to allow for, I would say, more standardized bleb surgery. Although trabeculectomy is still the king in terms of pressure lowering, we do see significant pressure lowering by these procedures. And I don't have enough time to go through these different options like Zen and pressure flow, but we certainly have seen improved bleb morphology with good pressure lowering in a safer manner, more controlled manner. And we have some good randomized trials that have been published, both for the gel stent and for the SIBS micro shunt, the pressure flow and Zen, that do show some differences. They do show trabeculectomy is still number one, but they show some benefit from hypotony protection, visual recovery, less ocular surface issues, and potentially safer option for these procedures. And we need to think about, however, that there are still some issues with combining cataract and bleb surgery. They're a bit antagonistic, right, in terms of their goals, in terms of their healing, and also in terms of the refractive status. On the other hand, MIGS surgeries are synergistic. They work on the same mechanism of outflow, and they still maintain the refractive neutrality of phaco and are more amenable. We do know that, of course, after phaco surgery, there's significant flare and blood aqueous disruption that occurs, and this can lead to increasing chance of bleb failure. So I personally like to avoid combining phaco with bleb surgery if I can, and typically try to separate them over time. What about MIGS with phaco? Well, there are many options for MIGS. There are, of course, cutting options to remove tissue and cut tissue. There are stenting options. There are laser options. There's dilating options. It's really a long list of procedures that exist. And in fact, I would say it gets very confusing. Many parts of the world don't have access to some procedures. Some procedures cost thousands of dollars. Other procedures cost $2. And so there's a wide range of options. And of course, they all potentially have an ability to achieve outcomes that are similar in different ways and different safety. We have stenting options, as I said, dilation and goniotomy or cutting options. And again, there's a fairly reasonable list of options that exist out there that we can look at that achieve, again, similar outcomes in terms of achieving outflow. We of course, very commonly see the eye stent, which has been a very popular device. It's the smallest device that we use in the human body, and certainly, in the eye, it provides for a very safe option. This is just showing the procedure here. Here we're using a double mirror lens, which we can do without tilting the microscope. And we see we're basically placing, in this case, 3 stents. This is the infinite version of the eye stent through the trabecular meshwork to basically bypass trabecular meshwork. This allows, again, for aqueous to bypass the pathology, trabecular meshwork, and get aqueous into the canal. And doing this earlier in disease, we feel can enhance outflow and can still take advantage of distal outflow of the vessels beyond the canal to achieve that. You can see this is a fairly elegant procedure. There's minimal manipulation of tissue, and we're able to, in this case, achieve 3 placements here. Very, very elegantly performed and done in a way to minimize disruption. This is truly a microinvasive approach. And we've found that more stenting can help by overcoming the resistance to outflow, hopefully achieving lower pressures. Here we're using the eye track, which is a microcatheter that can inject viscoelastic, because we know the pathology in glaucoma is not just trabecular meshwork, it's also canal collapse, the collapse of the canal, and also distal outflow obstruction, meaning beyond the canal. And here we're, by doing a goniotomy and placing this microcatheter inside the canal, we can dilate with viscoelastic. We, of course, are comfortable with Helon and Helon GV, for example. And by placing this catheter and injecting viscoelastic here, we're dilating the canal and we're opening up the distal outflow beyond the canal, beyond the trabecular meshwork. And this will hopefully overcome the resistance downstream. This light helps us to pass the catheter around. This is very similar to the approach of GATT, gonioscopic assisted transluminal trabeculotomy, which basically is another option to use, which we'll mention that. But this catheter is passed all the way around, and we've injected viscoelastic here inside the canal, all the way 360 degrees. We can also use this catheter to perform an ab-internal trabeculotomy, where we use it to cut the trabecular meshwork. And cutting procedures have been found to be quite effective because they remove the pathology. Now, they certainly are more involved than stenting, but they do provide a large area of access of outflow to the collector system. This is something we typically would use, for example, for a patient who has a bit more advanced disease, more than mild disease, and someone who has more medication load. We're also placing some stenting to keep the spaces open. So this is the ultimate here, where we're viscodilating, we're cutting the trabecular meshwork, and we're placing stents to maximize physiologic outflow. And I look at this as an example where we think about cardiac surgery. Angioplasty, stenting as one option, and moving toward bypass when the disease is more advanced. But we don't need to do bypass surgery when the disease is not so advanced. And this is an option for that. Now, there are some very good low-cost ways to achieve similar tissue results. I think we're familiar with GATT. This is 5-O-proline. The tip is melted here. We approach this again by making a goniotomy. We can then pass the suture 360 degrees, and we can perform removal of tissue, cutting of tissue, either 180 degrees or 360 degrees. We do either approach. And this is a method that can be used around the world using a very straightforward, simple suture, which costs, maybe $15, $20, and placing the catheter around with a micro tire. Now, of course, we don't know where the suture is going as well as we do with the catheter, but in most situations here, we can judge where it is, and we can pass it 360 degrees around and perform a goniotomy, where we pull the suture and we cut the tissue all the way around to move trabecular meshwork. This is, again, a procedure that can be done around the world in developing countries in a reasonably effective way, 360 degrees. Another way is using the bang, which is a 25 gauge needle, bent angle needle goniotomy. This can be used with a 25 gauge needle. It costs a few dollars. And we bend the needle tip here, and we use the needle to perform a goniotomy. This allows us to incise the trabecular meshwork, pass the needle circumferentially for 90 degrees, and remove, in this case, a piece of trabecular meshwork, or cut if you don't remove it. And so we're able to achieve this. My point is we're able to achieve these outcomes here with even technologies that are low cost. Here you can see I'm removing trabecular meshwork. Now, what's the difference between these options here? Well, I think that's still something that we need to prove. And these procedures really work well for patients who need a pressure in the mid-teens, and the goal being less drops. Now, I'm a big fan of evidence, and I do feel it's important that we always have to maintain a high level of evidence. And I would say that we have good data now to support the ability of using MIGS procedures to safely lower pressure, lower medications, improve quality of life, protect visual fields, and require less future surgery. Those are some pretty big claims when I talk about MIGS here versus medications. And I hope to give a good argument, because we see increasing number of publications. There's been a lot of editorials written, including from some of myself and some of my colleagues in Brazil. And what we've shown is that most MIGS procedures do lower pressure, as you see on the meta-analysis, amongst standalone or combined MIGS. This is pressure lowering here on the left, medication reduction, standalone, or MIGS combined with phaco. So they all, to a certain extent, provide pressure lowering. Now, of course, the data is highest in the implants, iStent and Hydrus, with large samples, expensive studies, and they are industry sponsored. On the other hand, when we think about non-implant procedures that are cutting, these are lower quality, but they are larger in number and often a more diverse patient selection. Let me give you an example of the Horizon trial. This is a trial that compared the Hydrus device, which is another MIGS device shown here, and placed inside the eye, as you can see with this video. You can see the device being placed in the canal here with an implantable injector. And this provides, again, access to the trabecular meshwork, dilating the canal and allowing for a bypass. We have 2 publications recently, 5-year data, comparing the phaco alone versus phaco plus MIGS. This was, I think, a fairly robust design, randomizing patients to phaco alone versus phaco plus Hydrus, 3-to-1 ratio. We washed out patients at 2 years, and we have 5-year data. And the data showed at 2 years that washing out patients, there was a significant difference in pressure lowering. Combining phaco plus MIGS lower pressure more than phaco alone. Now, phaco does lower pressure, no doubt, but adding the MIGS lower pressure more, and over time, there was less medications needed. Of course, when we treat glaucoma, we treat medications when we need to, of course, and so the pressure over 5 years was pretty similar. That's expected. But medications were what different between the study groups, and we found less patients on medications or medication-free when we combine phaco plus MIGS versus phaco, to an advantage for phaco plus MIGS. Now, what did this show? It showed a reduced need to go on to trabeculectomy, 3 times less likelihood than when we did phaco alone. We found that this combining phaco plus MIGS lowered the visual field progression rate by 50%. And so there's something to be said by lowering pressure by non-drop methods. This is an argument, I believe, very strongly that we must consider combining MIGS with phaco. Even the pressure lowering is modest, medication reduction is greater, and this leads to improvement in stability of disease and less need to go on to more surgery. Now, does this data apply to all MIGS? Well, we don't have the data for all MIGS or to all patients, but it gives us a certain hint that there's something there that we need to think about. Switching to quality of life, we know that there's certainly an improvement in quality of life because of the medication reduction on quality of life scores and ocular surface disease index by lowering medication use. Again, my cornea colleagues will be happier seeing some of these results. I have to mention, of course, sorry for Namrata being here. Now, again, I'm a big evidence guy. We do have some good reviews, Cochrane review, which again, I think has really nicely shown greater medication reduction, unmedicated pressure, change of medications when we combine MIGS with cataract surgery versus cataract surgery alone. Now, MIGS is not for everybody. There are advanced patients that we need to go beyond MIGS. And the mistake sometimes we see is that surgeons get too excited for MIGS, and performing MIGS for patients who have advanced disease, the outcomes just are not as good. They're not as good with patients who have more advanced disease, for example, as we see here, than patients who are milder, whether it's combined with phaco or not. In the end of the day, our goal is to choose the best procedure for our patients. And when it comes to cataract surgery, we can do cataract surgery alone. We can do a bleb later on. We can add MIGS and do a bleb later. We can do phaco plus bleb surgery, and there's different options to use, whether it's a MIBS procedure or trab or tube, or do a bleb surgery alone. These are all options that exist, of course. And there's no one size that fits all, but our goal again is to choose wisely for the right patient, the right procedure at the right time, as always. And what factors do we look at? Well, is the pressure controlled or not? Is the patient progressing? How severe is the disease? How tolerant is the patient of our medications, and how old is the patient? And we have a variety of options today. Trabecular MIGS, Schemm's canal, suprachoroidal MIGS, microinvasive bleb surgery, trabeculectomy and tubes. It's great to see all the options that exist. And they each have their own balance of safety and efficacy. We know Schemm's canal is very safe. Subcon surgery is very effective. And depending on the pressure target, we can then select whether we decide to do phaco alone, do MIGS surgery with phaco or not, or alone, or MIBS, or trabeculectomy. And I certainly think in glaucoma, it's wise to think about moving in a stepwise fashion, where we go from lower risk, lower potency options to higher risk, higher potency options that exists. Of course, if a patient needs bleb surgery, these patients require, of course, a more aggressive option. On the other hand, if a patient has controlled disease, then we like to avoid bleb surgery. We need to consider perhaps combining MIGS with phaco. Based on the data we've shown, we can have a greater chance of medication reduction, visual field protection, quality of life, and reducing the need for more surgery. And even if the patient is not as well controlled but doesn't have severe disease, I still do like to look at MIGS. We have a lot of success in these patients, and we can avoid bleb surgery. Even the pressure is out of control, it's a good step to do. But of course, if the pressure is not controlled and the patient has progression and advanced disease, we know we have to go to more advanced disease. And these are patients that do require bleb surgery. So I hope I've been able to share a little bit about where MIGS fits in today's world. Obviously, to me, the most logical place to think about MIGS anywhere in the world is thinking about cataract surgery with patients who have glaucoma. Obviously, there's still a role for patients who don't have cataract, doing it on their own. But I think the first place for surgeons to think about is when a patient has cataract and glaucoma, should we think about combining MIGS with cataract? And this is based on disease severity, the control of progression, medications, and the risks. And again, advocating a stepwise therapeutic approach, I think, is important as we look into this phase. So I do believe that, this era of interventional glaucoma has changed the world mindset of glaucoma. MIGS is one component of that. Lasers are an option. I know coming to India, we had a lot of discussion about lasers. Does it work or not? Many surgeons have found laser doesn't work as well, but I think the patient selection is important here, because using laser or MIGS later on in disease, when the disease is not reversible, the outcomes are not as good. But using it first line or earlier in disease, we see a better outcome for obvious reasons. The disease outflow process is more reversible, more malleable, and that's the place where I think these procedures work best, hopefully to avoid more aggressive surgery and to hopefully improve the quality of life for our patients. So again, thank you, बहुत बहुत शुक्रिया for having me here. That's my little bit of Hindi. हमारा हिंदी थोड़ा बात कर सकता. My father was born in Patna, so I picked up some language. But thank you very much again for having me here, and I look forward to more questions.
Thank you, Dr. Aiki. It was a wonderful talk. Just before I open up to the panelists, I have two questions to ask for you. What is the current role of MIGS in angle closure disease? Number one. And number two, what is the role of MIGS in a phakic eye?
Two great questions. So we need more evidence for angle closure. And here's my perspective. Phaco alone is very effective for angle closure. We know that. So the big question for me is, do we need to combine MIGS? Looking at data, we do know that in angle closure, there are about 15, 20% of patients, even with phaco alone, even opening the angle alone, there still is outflow disruption. They still need medications. Pressure is still high. They need more surgery. So we know from studies even on histopathological level that chronic appositional closure, which iris hidden trabecular meshwork, leads to trabecular meshwork disease at a cellular level. And it's worse if you have PAS, peripheral anterosynechia. So for me, if a patient has long-term chronic angle closure, the pressure is very high, they have PAS, I think phaco alone, I don't know if I'm going to get the pressure low enough. I could do a bleb surgery, but combining phaco plus trab is higher risk. And I do have had good success combining MIGS with phaco in those situations. We have to figure this out still, but I think it's a low risk option. So I say, why not try to improve the success of phaco in angle closure? There are a few caveats, though. In angle closure, we have a higher risk of PAS formation, peripheral antisynechia, to the angle, because the angle insertion may be quite high in these eyes. So we need to think about this in terms of choosing the right procedure that can reduce this, whether it's a small goniotomy or smaller implants, for example, in these eyes. Now, the phakic patient, of course, going into the eye in a phakic patient, we risk cataract formation, and we, of course, need more data. I do find in the young patients that angle procedures work well. We know, for example, congenital glaucoma, goniotomy works fantastic. I mean, not fantastic, it works quite well. We can avoid bleb surgery. And I believe juvenile glaucoma, meaning patients who have glaucoma under the age of 40 or 50, have some form of developmental glaucoma that does reasonably respond to goniotomy, trabeculectomy, MIGS procedures. So I will look at those options for patients who are younger, uveitic patients, for example, as well. But if they have advanced disease, then I typically still go to a bleb because we need to get that pressure very low. So I think there's a role for MIGS in phakic patients who have milder disease, uncontrolled, without with progression, that we can afford to do something less aggressive. And I think that's where, for me, MIGS in phakic patients or in pseudophakic patients, standalone, I think has an option.
In angle closure disease, when you combine the GSL with the mixed procedure, what is your choice? Would you go for an incisional goniotomy or would you go for an implants?
Well, I'd like to do gonioscopy, absolutely. And I think I don't know what the answer is, to be honest with you. I think that they both are reasonable options. I do like using small implants. I feel that they are well tolerated. So I will go for implants typically. But I think that if one does not have access to implants, I think a goniotomy can work reasonably well as well. I do keep patients, for example, on pilocarpine if I need to, if the angle seems crowded, because they can get synechia formation. So it's something that I think about in these eyes that have angle closure. But obviously, listen, we need more data to really try to, choose one or the other. The thing with implants are, whether they're angle closure or open angle glaucoma, they're very technical dependent, technique dependent. It can be too deep or superficial or not well placed. So I find that's a variable that it's a learning curve. Goniotomy, on the other hand, you can just, you know your outcome. You're cutting, it's right in front of you. So goniotomy is easier to learn in that sense, but stenting may provide a safer option, a more controlled option, less likely to close, but it does require technique. And that's why I think we see differences in results, because putting it in perfectly is not always easy.
Thank you, Dr. Aki. Dr. Satyan, over to you.
Thank you, Amit. And it's a wonderful talk, Dr. Aki Ahmed. Thank you so much for your wonderful talk. And I have the question on how do you really kind of convince the patient? Is that your counseling has become a little different for the patient to accept to go for the surgical option, that is the interventional glaucoma procedure option directly? How much it has changed in your practice?
It's changed a lot.
Yeah.
I'm sorry to cut you off. I think it's a very good question. I've seen it evolve over the last decade, where initially there's skepticism, but now patients are coming in even asking to say, well, can we actually treat this without medications? We've changed so much now with the way the communication and education has happened. But this took a long time. And I think when I visit India, I do talk to many of my colleagues, and there's a lot of skepticism about the motivation to do these procedures. Is it going to work? The risks, everything else. So I think it really does take time for this. I think education is always important. I think showing the proper data is important. And most of all, our patients want to be comfortable with the safety. For example, I think we have very good safety with SLT, very good safety for certainly some of the implant MIGS that we have, to be very reassuring of that. The other part of it is to remember that unlike cataract surgery, the success rate will be quite variable. Some patients may not respond well to MIGS. Some patients will get partial, some patients will get a bigger effect. And we hope that we will be better at predicting success based on a variety of phenotypes and genotypes eventually, to be able to give a better, accurate assessment. So I always counsel my patients, number one, the reason to do MIGS, especially since we're in the eye. We're doing cataract surgery already. The increased risk of adding MIGS is very small compared to doing the surgery without MIGS. So it gives my patients some comfort level. That's my own experience. Number one. Number two, my goal here is important to clarify. It's maybe medication reduction or pressure reduction, or maybe both. So patients don't expect to have pressure of 12 with no medications. It's very important. And often patients come to us thinking that we're talking about trabeculectomy. We need to clarify the difference between the two procedures. And also say that glaucoma is a chronic disease. This is one step in many steps that may be required to achieve, quality of life and long-term protection of vision. So it takes some time, of course, to do that. And I know for many people that time is too long, right? Why not just do cataract surgery and keep them on the medications? And that's the easy route to go through. But I think our job is not necessarily what the easy route is, it's what the right option is for our patients.
Thank you. I just asked one more question. Have you seen something similar to our trabeculectomy, that the fluctuations in trabeculectomy patients versus medical therapy, definitely the trabeculectomy is much better. So the progression of glaucoma is much, much lesser in post-trabeculectomy eyes. Is that similar to that you have seen in the MIGS as well in comparison to the medications?
Yeah, it's a very good question. I completely agree that with trabeculectomy and bleb surgery, in general, whether it's Barevelt or trabeculectomy or Zen or PreserFlow, it really flattens that fluctuation, and the data is pretty good on that. We have more data coming on MIGS and laser, for example. So SLT, we have a study we've done, which shows a flattening of the peaks on, for example, home tonometry, home measurements. And we're seeing the same thing in MIGS. Now, of course, it's not going to be trabeculectomy. Trabeculectomy is the best, right? Of course. But it does help to flatten those peaks compared to medications alone, even though the office pressure may be similar. And so I think we're seeing that. We have data even looking at 24-hour pressure control with contact lens, data with home tonometry, and data with diurnal fluctuation. So I think more data will come on this, but early data indicates there's some improvement on this, but to some variability compared to trabeculectomy. And I think that's one of our goals. And one of the mechanisms by which we see some of the results, for example, the Hydra study, pressure is the same after 5 years, but one group had more medication than the other. Why does one group have less progression? Why does one group have less secondary surgery? Well, one will be compliance, the other could be better pressure, better 24-hour control. So that's still to be evolving.
Thank you so much. I have many questions, but I will allow the other panelists also to ask some questions.
Question box
Thank you
is
so
filled
much.
with multiple questions. I don't think we can take any of the questions on the question box. Yeah, any other panelist, Dr. Manish, Dr. Parul?
So
Please
I would
unmute
like
yourself.
to ask Dr. Ahmad, you had talked about all the time about SLT, and for us, those of us who are doing SLTs and getting good responses, when the same patient is due for cataract surgery, do you think that the patients who do well with SLT are the ones, the same phenotype, who will do well with the MIGS?
Yeah, a good question. My feeling is that the answer is yes. I wish I had better data to support that. The problem these days is, at least in my countries here, everyone has SLT. So we don't have a group. We rarely have a group that has not a SLT. And then to judge the response isn't always clear. They may be at SLT many years ago. So my gut feeling is, though, that yes, I think that there's a response relationship between SLT laser and MIGS. Some people have also looked at pilocarpine. Pilocarpine is an indication for success. Again, the data seems to indicate that there's some correlation, but we really need to have better data. It makes sense, though, right, that there would be some potential correlation.
Parul, you had a question?
Yeah. So building on the SLT concept. So if you have a patient who is doing well with the SLT and suddenly, you see that it's not becoming as effective, would you like to add on a MIGS to this patient, or vice versa? You have a patient who had an eye stent and is now starting to lose the efficacy. Would you like to supplement an SLT? So either cases, would you like to complement them?
Yeah, I mean, I definitely would look at repeating SLT. If I had SLT already done once and it's successful, I will repeat it again. We know that there's good data on repeatability. And if I'm doing cataract surgery, for sure, I will add MIGS to the patient if they've had SLT already and they lose control. So I think there's a benefit in doing MIGS after SLT, and the same thing for MIGS and then have SLT afterwards. I think there's no reason why we couldn't do SLT after MIGS. We know, of course, that with more SLT repeating, that the efficacy does tend to wane off more. So there's a certain limit, of course, for that. But the general premise is that, if you have not had SLT or you've only had one treatment in the past, I think there's a reasonable chance to do SLT after MIGS. Especially, for example, some of the procedures we do that dilate the canal, because we perhaps can, we've rejuvenated the canal, the outflow system, and now the trabecular meshwork continues to, of course, develop their outflow dysfunction, collection of extracellular matrix, and SLT laser can address that. The key for SLT laser to work, though, is reversibility of disease, right? Once the disease is irreversible, fibrotic, scarred down trabecular meshwork, it's not going to work. So that's why SLT first line works well. That's why treating early works well. And that's why maybe after MIGS, after we reestablish some outflow, maybe that may provide some benefits. So I think the option is, though, quite good. And the safety of it, of course, gives us comfort in doing it again.
Another question. In your experience, how long does it take for a patient who had MIGS to eventually require a tube or a trab?
I mean, if you look at some of our data, 5-year data, of course, it depends on the severity of disease. It ranges anywhere from 4 to 10%. With the reduction, of course, when we combine with MIGS. So that's what I would generally say. Of course, it depends on the severity of disease. If you have more advanced patients, you're going to need more patients who need to have a trab or tube. But the bigger point is that we always need to think about the next surgery, right? Whenever I do a procedure today, what will my patient need in a few years from now? And I think the benefit for MIGS, I should mention, is that at least we feel it shouldn't have a negative impact on a trab or tube, right? On the other, in fact, you should have a positive benefit. If we reduce medications on the eye, this may protect the conjunctiva in a better way, at least for some years. So when a patient needs to have con surgery, maybe the conj is better shape. Maybe, I say, of course. But the benefit here is that I don't think it affects the surgery in a negative way. We still keep the conjunctiva real estate. We don't touch the conjunctiva for our MIGS procedures. And we set them up for potentially still needing more surgery with the benefit of that surgical approach. That's what I would say for that.
Yeah, thank you.
Yeah, thank you, Dr. Amit, and thank you, Dr. Aik, for a wonderful illuminating talk. I will take a few seconds to put things into perspective in terms of the MIGS still being new for a large section of the audience. I belong to an era of ophthalmologists. When I started my ophthalmology practice, the multifocal lenses were still coming, very new in the market. And it was almost looked like it was wrong to prescribe multifocals, and people would think that it was financially motivated. And we have now reached an era where the multifocal lenses have become trifocal, and we have so many choices in between, and their benefits have clearly been proven over time. And it almost feels wrong now not to offer this intraocular lens to a patient when they are undergoing a cataract surgery. So over time, we have also reached a stage when, as you said, probably MIGS should be offered to all patients who are undergoing cataract surgery, even when they are controlled. And in our setup, the biggest beneficiaries are the patients who are non-paying in nature, those who don't pay for any treatment with us. So we would 5-10 years back would only do a cataract surgery and expect temporary and small improvement. But with low-cost MIGS like Bang and GAT, a lot of them are free of medications for a significant amount of time, and that makes a huge difference for those category of patients. And I will end up with one question for you. Just like in angle closure, where Eagle has shown a huge benefit of taking the lens out, but you don't do it for patients who are PACS or primary angle closure suspects. How early is too early for MIGS?
Yeah, great perspective. I think that we need to be responsible, first of all, to your question about the motivation. I think that, unfortunately, there are going to be some people who do procedures for financial motivation. That's the reality of human beings. We need to, though, do it for the right reason. So I'm glad you mentioned this. I think the majority of us do it for the right reason, and we need to make sure we build the data to support that, first of all. There's also a potential risk that it becomes overused. And I always advocate, as much as I'm enthusiastic and passionate, we have to always be cautious in terms of making sure we do it responsibly. I think that's important. In terms of how early to do MIGS, I think, for example, if a patient has a cataract and they're going to surgery, for me, I feel very strongly that there's no time that's too early. I mean, why not? We're going to cataract surgery. Let's do it. We're already in the eye. The incremental risk is not much greater, and we have a benefit that we've shown by good evidence. But doing standalone is a bit different story. You know, you come to me, you know, you're a young guy. Well, you're 25 years old, right? You know, somewhere there. Let's suppose you're 45 or whatever, you know, and you're newly diagnosed glaucoma. Okay, I'm comfortable doing SLT laser. I think that's very comfortable. You have 3 decades of work with this. But am I going to do MIGS for you without adding drops? No, I'm not going to do that because I'm not yet comfortable and confident that that's the first best option for our patients. Not yet anyways. Maybe the day will come where we do get comfortable with it. Usually for me, it's going to be somebody who's already been on some drops, maybe a couple drops, 3 drops, and still they're not controlled or they're progressing, where I go and intervene for standalone. That's why I say MIGS is ideal for cataract. On its own, we're typically still moving this toward later on in the disease continuum of therapies. Now, drug delivery is interesting. Drug delivery now, we're using drug delivery earlier too. So I see these procedures moving earlier and earlier as we become comfortable with the safety. And right now, though, cataract is really that opportunity. I think that if you're not doing first-line SLT, I would give it a strong consideration. If you're not doing phaco and MIGS, I would give it a strong consideration. You're not wrong in not offering it, but I think there's so much data now, so much comfort and safety that it's worth giving it a good look. And I'm happy to see that.
So
Thank
Devang,
you.
can we have a question from you?
Yeah, thank you, Dr. Ike, for the wonderful talk. So, MIGS is mostly explained, is done in primary glaucomas. So, what is your take in secondary glaucomas?
I think, you know, the most classical examples are pseudoexfoliation. I think we've had very good success in that group of patients. It's a proximal disease in some senses. Pigment dispersion, similar success. Obviously, as we get more exotic, the chance of success do reduce. For example, obviously, raised episcleral venous pressure, I don't think would work. Uveitis can be variable. If it's not active uveitis, I find reasonable success. If there's a lot of synechia, a lot of activity, not so much. Obviously, neovascular glaucoma, not so much. You know, those are what I would basically think about as far as secondary glaucomas that we see. But I think the classical ones we see most commonly here, pseudoexfoliation, we are very happy to do it in those cases. Traumatic glaucoma can be quite variable depending on how much disease is in the angle. But I think it's worth a shot if the disease is not so severe. The benefit of MIGS is that we have a chance to do something with low risk. If it doesn't work, we could do something else. So it's worth a shot in those diseases. But some diseases are like just not worth trying, like I said, with some of these more difficult secondary diseases that have more dysfunction than just simple trabecular meshwork.
Dr. Ike, we just had a question of similar kind what Devang asked from the Middle East. The question was, what is your favorite surgery for pseudoexfoliation syndrome? So the answer.
Well, yeah, I mean, I think if I'm doing cataract surgery, we believe that cataract surgery is more beneficial in pseudoexfoliation than non-pseudoexfoliation because of mechanisms in the trabecular meshwork, and the same thing with MIGS. So, you know, I don't really make a difference for me between POAG and pseudoexfoliation. I will do MIGS in a way I choose, and I do bleb surgery as I need to. You know, we do debate: is stenting better? Is cutting better? I mean, I cannot tell you the data is really solid one way or the other. I would do what's best in your hands. If you're comfortable with stenting, obviously it's very safe to do, but the success rate will be dependent on how well you do the stenting. While goniotomies, like I said before, you can do this and you know your outcome. You see the result right in front of you. So technically, it's less of a learning curve for that. So I think that's still a personal decision to make as far as what procedure you choose.
Thank you. Dr. Dipanjan, Dr. Devendra?
Yeah. That was an excellent talk, Dr. Ike and Dr. Dipanjan. I've just had your view. I wanted to have your view that how do you manage in the post-op situation? Do you take out all the drops and add when required, or you just continue with the drops and then take out if you feel that the pressure is lower than normal or something like that? How do you go about it?
Yeah, great question. I think the answer is it depends, of course, as usual. But one thing is this. For mixed surgery, sometimes it does take some time for the pressure to stabilize. And these patients also can be predisposed to, of course, steroid response. So the factors I look at are disease severity, IOP level, and medication count primarily. So, for example, mild disease, control pressure on one medication, I will for sure stop it. On the other side, patient who has more than mild disease, moderate or advanced even, they have a high pressure, 20, 22, 23, 24, they're on, 2, 3 medications. That patient, I'm not stopping their medications. That patient, I'm continuing at least some of them. Maybe I'll cut them in half. And then in between, there's some variability. There's no real harm in continuing medications for the most part. But of course, if you get lazy, you forget to stop them, and patients may be dissatisfied. So it's important to tell our patients beforehand, well, I'm going to continue medications after for a month, then I'll reduce them. So patients are prepared for that, because we don't want to see pressure spikes in the first few weeks after surgery, which can happen in these procedures. And patients have more advanced disease who are at higher pressure pre-op and more medication count. Those patients are at risk. The pressure may be good on post-op day 1, maybe it's 15 or 12, but in 1 week the pressure is 25 or 30. So for those patients, we want to continue some medications, and those are the ones where, again, are more than 2 medications, have more than mild disease, and have pressures that are, above 20. Those ones I will continue at least some of them. It's not usual to continue all the drops, but at least 1 or 2 drops for those patients. That's my quick answer for that. I've learned over the years. I used to continue all of them and stop them. I stopped them all of a sudden and see what happens. But I found that it wasn't always satisfactory for that. And that's how I kind of tailor my post-op medications. Steroids as well. Be careful with steroids. We use them, but taper them off, because patients do get steroid response, and that could sometimes be a problem as far as pressure elevations in the first 2 to 4 weeks, first 1 to 4 weeks. I tell my patients, listen, your new pressure will be about 2 months after surgery. That's your new baseline. So MIGS is not a one-shot deal. You don't have to do MIGS and then patient's gone. They do require some follow-up and some counseling, and making sure after 2 months we can stop medications if we continued them and reassess them, because that's the time where the pressure now is basically at a new equilibrium and steroids have washed out.
Dr. Ike, do you give postoperative pilocarpine for all your patients after incisional goniotomies?
I don't do routinely, no, but angle closure, I do, because those angles are tight, especially plateau iris, which is more common in South Asia. They have a high iris insertion, and they can have a higher chance of getting sneaker. So I typically keep them on pilocarpine early on in those patients with angle closure,
I'm
not
about
routinely.
open angle to prevent PAS formation after incisional goniotomy.
I find it's rare. So I know I used to. I no longer routinely use pilocarpine, but I will look at them post-op day 1. I'll check their angle with a light gonio, and if I feel they have a tight angle, they're getting sneaky, I'll put them on pilocarpine then. But I don't do routinely anymore. I don't do that personally. But again, each eye is different. Indian eyes may be different, right? Brown, thick iris, it may be different. So you have to customize it. And my experience may be different than your experience. So I would say that you should evaluate on those patients.
Thank you, Dr. Ike. It's always pleasure to listen to you. I think it's wonderful talk. So I have 2 questions. First question, this is a recent.
I think you're muted.
You're muted.
I think you're muted.
So recent literature suggested KDB and GAT has role in the advanced glaucoma. So what's your thought about this? And one additional question to this, like say young patient, juvenile glaucoma coming to us, instead of trab plus trab, can we take for GAT first? Then second procedure, we can proceed for the trab. Question 1. Then I will ask.
I love stepwise therapy, going from low risk to high risk. I like the idea. However, we need to have a high enough success to make it worthwhile, right? And we also need to be comfortable with safety. We know with GAT and KDB, there is a risk of pressure spike. There's a risk of this. Maybe it's 10, 15%, 20% sometimes. And that can cause someone with advanced glaucoma to snuff out or get vision loss, number 1. But more importantly, the probability of success in my experience is not as high. So I know there's been publications. I have an issue with them. I won't go in detail. I think the methodology is a problem. I think the way we report the data is not necessarily ideal. Because if you look at the data, many studies, we show 20%, 30% of patients need to have secondary surgery. They take them out of the analysis. So the pressure now is 12 because all the patients who need the surgery are gone from the analysis. It looks like the pressure is lower with GAT. But if you look at the studies in more detail, I do think that the success rate is not as high as I'd like it to be. So I don't usually do a GAT or KDB in advanced glaucoma. I need the pressure to be down to 12 consistently. I need to be comfortable with my bleb surgery. Now, for juvenile glaucoma, that is a particular situation where we do have more success, as I said earlier. So I will think about it more in those patients, but I will be prepared to do surgery earlier if I need to, and patients need to know that. And I'll be prepared. I need to put them on medications for the first month or two, because those patients maybe have a lot of fluctuation in their pressure. They have bleeding in the eye, pressure spikes. It's kind of stormy. So I don't always like to do an event. I'm a bit of a different perspective on that one. I typically am confident in my bleb surgeries. And I think advanced glaucoma, those patients need a good pressure control long term. I don't think mixed surgery works as well in those patients in the long run. And there's a short-term risk of pressure spikes. Success rate, I think, is not very high. That's my own experience. And of course, we'll have to look at more data on that one.
Thank you.
Dr. Aiki, it's
Yes,
already 35,
Yes,
and we have quite a few questions on the chat box. If you don't mind spending another 10 minutes,
Yeah, sure. I can spend more time. No problem.
because
I
it's
mean,
a
you
working
know,
time, that's the reason I asked. Okay,
it's
definitely go ahead with the-
India. It's India Standard Time. We don't have any time limit. Come on.
Amit tried to say in the beginning that we are going to be on time. And now it seems that it is Indian Standard Time.
That's okay. I'm okay if you guys are here. I can stay here, no problem.
We'll
So I
just
have
take
my-
another 10 minutes, that's all. Yeah, Devin.
I have my second questions. So I heard about the ACRS, about some of the group, some of in your group presented the outcome and safety and outcome of 180-degree versus 360-degree
Mhm.
stenting procedure. So my question is this: how were the outcome of 180-degree versus 360-degree? Question number one. And second thing, what the incidence of hypema is much lesser in 180-degree in compared to 360-degree.
Yes, I think that most studies have shown less hyphema with 180 than 360. That's the first thing. You're right. Second thing is, on a hypothetical level, on a outflow level, 180 should achieve similar outcome at 360. If you think about the outflow system and the resistance in the trabecular meshwork and the distal outflow resistance, meaning the collector channels, aqueous veins, once we remove 4 to 6 clock hours of trabecular meshwork, we should have the same resistance as getting 180. That's what we should. So I have generally felt that, although our data indicated there might be some trend toward increased success with 360. And I think that may be due to, for example, may do 180, but some of the angle may be closed, right? My fibrose, it may scar. So by having a larger opening, even though we may have some closure, we still retain a larger otomy that's kept. That could be one mechanism. Other reason could be that aqueous is segmental, right? 360 degrees, every area is different. So if you do 180 degrees in an area with good outflow, you make a good success. If you do 180 in an area where there's not so much good outflow, meaning beyond the canal, we may not get success. So 360 allows you to have access to all the outflow channels, whether they're high flow or low flow in that sense, or low resistance or high resistance. So those are some of the reasons why so here's what I do. For combined phaco, I only do 180. I don't want to have hyphema, and success rate to me is fairly similar if I'm doing goniotomy, 180, 360. On the other hand, if I am doing a child, a young patient, 8 years old, I'm doing 360 goniotomy. I feel that to me has had the great success, and I'm willing to take the hyphema risk because I'm doing the surgery primarily for glaucoma. And standalone in older patients, it depends again on severity of disease and medications. But I generally avoid doing full 360 in most cases in my hands. But I'm looking forward to seeing more data. Our group has shown again some differences, so we'll have to see where this plays out.
Dr. Aik, there was a study which was published by Dr. Zuren, which mentioned she compared 100, 120, 180, and 360. And she said 100 to 120 degree goniotomy gives similar results with 180 and 360. So no need to excise excess tissues. So
I believe that. But other data has shown different results. So I think we probably have to figure this out a bit more. But I would tell you my own personal belief. I agree with that finding. I think that makes sense physiologically, and it reflects my own experience. But I'm just going to add that when we look at multicenter data, like in our group, we did see some variation, some trend that maybe 360 was better. But that's my current review of the literature.
Dr. Aiki, we have a question from Singapore. This is Dr. Shelvin. She is asking, what is your opinion of suprachoroidal devices, example, mini jet, does the mini-eject work better than the bypass?
Same question I have. Okay, right.
Yeah, I mean, I think suprachoroidal space is a space that is like explorative. It's like outer space, you know, we're still exploring it. We don't know what we're going to get, but we may get some really good results. I did mini-eject many years ago, and I was one of the big investigators for their studies, and I do think that the pressures do lower quite significantly. We don't have any studies comparing mini-eject to CyPass, but I believe that the mini-eject should achieve a better success and better safety is what my belief is right now, but I need more data to support that. I think that the mini-eject works by maintaining a cleft, while CyPass works by having aqueous go through the device, at least in terms of the theory. And I think mini-eject is a soft device that keeps the space. It has less tissue reaction than a rigid device. So there's reasons why we may see a difference. Suprachoroidal space is interesting. I mean, it has the potential for greater pressure lowering than canal, but also there's some unpredictable nature to it. For example, hypotony sometimes can happen, shallowing of anterior chamber, hyphema, and even closure with pressure spikes. It's not common, but we still feel there's some variability that leads to some uncertainty with suprachoroidal space. So I look at it as a procedure that I probably would use it maybe after we've tried a canal procedure, but I don't want to go to a bleb, you know, kind of in the middle space there, because it can achieve results that get close to a bleb without creating a bleb. But there's some risk involved. That's why I think using it first line, for example, for early glaucoma or combined phaco, where it may affect the results of phaco, that's where I think there's still some question about where it fits in, perhaps again, more for the moderate patient, the more patient on more medications that may have a role there. So we're still evaluating it. I think we need the space, but we'll figure out where it fits in the whole paradigm between canal, suprachoroidal, and bleb surgery. Those are the big, of course, categories.
We have one more question in the audience. What is your take on gonioprexy? Which conditions would you advise gonioprexy? That's a gonio wash.
I mean, you know, people have talked about this, of course, and, you know, pseudoexfoliation, pigment dispersion, those are conditions that theoretically may benefit from those gonio irrigation or gonio aspiration techniques, as you mentioned. But I feel that I don't think it's going to be enough, and I don't think the data is strong enough to give us an indication of that yet. And again, if it's early enough, maybe there is some benefit for that. But I feel that whatever there is, it's going to be temporary, theoretically at least. And so I personally have not had a lot of experience in it, so I cannot speak to it. But I probably would be in there and do something more. I would rather bypass the trabecular meshwork in a more permanent fashion than simply just aspirate. That's my own opinion, but again, it's just an opinion.
Again, one more question was, does MIGS fail in ocular hypertension in stable lasered PDR? So this is a question in secondary ocular hypertension after stable lasered PDR. What is the role of MIGS? Is it success or is it failed?
So PDR, meaning proliferative diabetic retinopathy, diabetes? Yeah. I mean, those are difficult. They've got VEGF floating around. They tend to heal and scar. I mean, anything we do is going to be less successful. Is it worth trying it? I would say that if there's an open angle with no nevascularization, stable disease, not advanced disease, I think it's worth trying it. But I would say that I would suspect the success rate will not be as high. You know, that's my own thought of that kind of condition.
Last question. What is the
One
role
more
of
after
preoperative
this.
gonioscopy? Does it alter the type of MIGS selection?
Which one, sorry?
How important it is doing preoperative gonioscopy? Does it alter the type of MIGS selection?
Well, I mean, it's essential to do gonioscopy, absolutely. And I think one thing that MIGS has made us is better gonioscopic surgeons, right? So I think gonioscopy is critical to be able to make sure the angle is open or closed. If you're using stenting approaches, you may want to maybe look at some areas of pigmentation maybe, or you may want to look for any anomalies. So I think it is important to do gonio for everybody, of course, pre and post-op, I believe, and be comfortable with gonioscopy. If an angle, for example, has light pigmentation, it may be difficult for you during the OR to see the trabecular meshwork. In that case, you may want to inject trypan blue or take a better look at it to make sure you know the structure so you can be prepared. So I think it is a good thing to do, and I think it makes us better clinicians by doing good gonioscopy.
So
Thank you.
one last question.
Yeah.
One last question. What about following keratoplasties, use of MIGS, especially post-desec, where the angle doesn't get distorted. So has somebody used it?
Yeah, great question. I mean, I think, as you said before, a lot of it depends on the angle architecture. PKP eyes, can have a lot of angle anomalies or synechia and everything else. Those eyes, I don't think they do respond as well. But now with the age of lamellar keratoplasty, I think these eyes are very amenable to, especially when they have not had like necessarily chronic glaucoma, I think that they have a good chance for success. Now, the interesting question is steroids, because of course, many of your patients need steroids. How does MIGS work in steroids? Well, if we don't necessarily understand how does steroid response happen, but if it's at the trabecular meshwork level, it makes some sense to bypass trabecular meshwork and remove some trabecular meshwork even, and therefore the patient will have less of a steroid response. And I think we do see this success in patients with steroid response glaucoma, although I still think steroid response can happen. I think it can work well on that. So I think that, yes, we have done it with my cornea colleagues in patients with DSEC, for example, with reasonable success. But with steroid response, I think the result is more variable. I think it's worth trying if the disease is not so advanced, because we don't want to do a trab on that patient, of course, if we can avoid it. So I think, again, we need more. My answer very commonly is we need more data, right?
Yeah.
As you know. And I want to just, again, as we close, say that, listen, I mean, I definitely want to encourage us all to try to do the best studies to try to evaluate this. We need, for example, more data on the results of these procedures in Indian patients, right? The data presented to you was primarily Caucasian patients, non-Indian patients. So we need to get good data from you all, from colleagues. We need industries to support this, for example, because we really need to understand the role of these procedures in different populations around the world. I mean, India, Asian, I mean, all type of eyes, African eyes, very important to do that. And I think that's important as we kind of generalize our results to more populations.
Thank you, Dr. Agi. Coming to the Indian data, we have Dr. Devendra, who has published quite a few articles in the Indian Journal of Ophthalmology on MIGS. I have won an award for my data on MIGS, that is Bang and KDB. So we are working on it. And before I
Great.
go to the closing remarks, I just request all of you to please be visible on the screen. We had a purpose for this webinar. We wanted to learn a lot of things from Dr. Aiki, because MIGS is evolving in India, and I purposely made everybody wear colorful clothes. We didn't want to wear black clothes. Let not glaucoma darken your life. So we all are wearing colorful clothes. There was a theme. We come with a coffee mug. We all sit in front of the screen with a coffee mug, with a colorful t-shirt, so that we brighten the vision of all our patients. So I just request Devendra or Siddharth to just take a group photograph of all of us with everybody's screen visible before I put the closing remarks. And thank you, Dr. Ike. Seriously, thank you.
Thank you, Dr. Ike.
Same,
I think you're really very
same
busy.
MIGS.
Yeah,
Yes.
MIGS. No, but I think you're
Same
really very
MIGS.
busy, and to take your time out of your schedule and spare this for us, it's really very gratifying, and thank you so much for doing that. And hope to see you in
Thank
April.
you.
Hope to see you in
Oh.
APO in April in India.
Thank
again.
you. Thank you so much. I mean, you're such a role model, Namrata, and all of you here. And I was just going to say that next year's a big year for India. We have APAO and APSCRS. Delhi for APO and Ahmedabad for APSCRS. So it's a big year to highlight India in the world. And I look forward to seeing everybody there too.
So before I conclude, I would just give the vote of thanks. I would thank a lot to Dr. I.K. Ahmed for accepting invitation. We tried to get you for a long time, and finally we were able to manage. And the purpose was only to have you as a speaker and not multiple speakers, so that we can clear all our doubts. And it was a very successful webinar. I also thank my chairperson, Dr. Namrata, who constantly pushes us to conduct this type of webinars, so that all our delegates gets benefited by it. And it is because of her constant motivation we are able to conduct this webinar. Also, my panelists, my mentor, Dr. Satyan, the President of Glaucoma Society of India, Secretary of Glaucoma Society of India, Dr. Manisha, my very close friends, Dr. Devendra, Dr. Siddharth, Dr. Dipanjan, Dr. Parul, Dr. Devang, all of you for making this webinar a great success. And also my governing council members of All India Ophthalmic Society, our President, Dr. Sama Basak, our Treasurer, Dr. Manoj Mathur, our Secretary, Dr. Santosh Onawar, and the whole governing council, who is always a backbone of all our webinars. And I would also like to acknowledge Sun Pharma for the contribution in this webinar. They made this webinar more colorful and more lively. So thank you all once again. Madam, last remark from your side, Dr. Namrata ma'am.
I think you've said everything. Let's not stand between what Dr. Ike has to do now. We've, as
Oh,
it
no
is,
problem.
overstepped our time. Thank you so much, Ike. Thank you.
Thank you so much. Thank you.
We've had one of the largest number of audiences today, both
I
on
didn't take a toll
YouTube.
of that.
No, I am taking a toll of it on YouTube, on Facebook, as well as on our portal. Thank you. Thank you.
Thank you so much.
Thank you again. Be well. Be well. Thank you.
Thank you, everybody. Thank you, Ike.